So now we're ready to look at chest X-ray interpretation, part 2, which we're going to be looking at pathologic conditions we see in the NICU. So one of the most common things we see is respiratory distress syndrome. So an X-ray of a preemie with RDS will show usually small lung volume. Remember, we can tell the inflation of the lungs. We want it to be between T8 and T9. We'll see these things called air bronchograms, which are air in the airways of the lungs that are black in comparison to the surrounding white areas that do not contain air. In other words, the alveoli, which are usually full of air, that surround the bronchioles, are collapsed. They are not full of air. So because they're not full of air, they're going to appear denser on the X-ray. So it gives you a granular looking areas of the lungs where the lung resembles, some people call it white salt and pepper being sprinkled on the film. Some people call it ground glass appearance. Some people will call it a granular look. Cool. So here are some examples of RDS. When you look at an X-ray, it's very helpful to also know the clinical background of the patient. That's why it's so important when you have a patient who has an X-ray to look at the X-ray and correlate it to the clinical condition of the baby. So here, these are all preemies that we're looking at. Remember the X-rays that we had looked at before? This area of the lungs was nice and black. Well, now it's what we call whited out. All the alveoli are closed. They're not full of air. And you can see these black streaks within that white tissue. Those are the small bronchioles, the tubes that are full of air, and they're surrounded by collapsed tissue. We can still make out the borders of the heart for this preemie. Over here, you can get a better idea of these air bronchograms. This is what they're talking about. These black lines are the bronchioles that are going all the way up to the lung tissue, but are surrounded by collapsed lung tissue, which makes them stand out. So here we have a before and after picture of a baby before they get surfactant. You can see we've lost the borders of the heart. Remember that lung tissue actually overlies the heart. So the lung tissue is completely collapsed. Alveoli are collapsed. We can see here is the carina right here. Our ET tube is here. It's a little high because we see the clavicles are here. If we want to keep this baby intubated, we would have them advance the ET tube a little bit. So now they give surfactant, and a little while later get another X-ray, and you can see that the baby is already starting to improve. Here the inflation was 1, 2, 3, 4, 5, 6, 7, 7.5, maybe 8. And here the inflation is much better. Here we are 1, 2, 3, 4, 5, 6, 7, 8, 8.5. We can see the heart borders much better. And you can see that the alveoli are starting to open up. We're getting some darker lung tissue here. ET tube, still a little high. We're up here, clavicles are here. Carina, I think it's hard to see, probably about here. TTN, transient tachypnea of the newborn. So TTN is mostly seen in term babies. Can be in late preterm babies, early term babies. It's a condition that causes breathing problems, mostly of tachypnea and oxygen requirement. Because babies have fluid in their lungs before birth, the fluid normally goes away very quickly when a baby is born. In some babies, that fluid does not go away as quickly as it should. We call it retained fetal lung fluid. There's another condition that we also see called pulmonary edema. It can also cause respiratory distress in newborn infants. It can occur with perinatal asphyxia, babies in heart failure, baby has significant and persistent RDS, if there is a persistent patency of the ductus arteriosus or a PDA, the baby has pneumonia or chronic lung disease. So in order to tell the difference between TTN and pulmonary edema, sometimes it's important to know the clinical, to correlate it to the clinical history of the baby. So here we have a baby, a full-term baby, who has TTN. Remember how we talked about this horizontal fissure is important to us? It's important because here we see it on X-ray. We call this fluid in the fissure. It is pathognomonic for TTN. So we can correlate this X-ray with the baby. The baby's a full-term baby. He was delivered by repeat C-section at 38 weeks. Before labor starts in a baby, there is some signal that's sent to the fetus to slow down or even stop making fetal lung fluid in preparation for delivery. If a baby is delivered by routine repeat C-section, the baby may not have started to slow down his fetal lung fluid production. This baby was born at 38 weeks. He's a couple weeks before his due date. He's up until the moment he is delivered, he's continuing to make fetal lung fluid. So there's a lot of fluid here that needs to be reabsorbed. So this picture here shows a lot of fluid in the fissure, fluid in the lungs that just needs to be reabsorbed before the baby can recover. Not to be confused with pulmonary edema. Pulmonary edema is when the baby is what we call fluid overloaded. We can see that these lung markings, which are the vasculature of the lungs, the blood vessels, are overinflated, causing the baby to retain too much fluid. So this would be more of a premature baby who is older, who is convalescing, who perhaps needs a dose or two of Lasix to recover. So you hear us use the word atelectasis a lot. So atelectasis is just a condition in which the airways and the air sacs, the alveoli in the lungs, collapse, or they don't expand properly. It can happen when there is an airway blockage, if there's a mucus in the bronchioles, or when there's pressure outside the lung to keep the lungs from expanding, or when there's not enough surfactant for the lungs to expand normally. So atelectasis can occur for whole lobes of the lungs. It can occur in what we call patchy atelectasis, meaning there's just areas, small areas of the lungs that haven't inflated properly. So here we see this whole right upper lobe has collapsed. It's consolidated. This is right upper lobe atelectasis. So why might that have occurred? Well, remember from our picture, there's a bronchiole that comes off up here that supplies the whole right upper lobe. If there's mucus here, or what we call a plug, we're going to plug up this whole bronchiole, and this whole that supplies the entire part of this lung. So this whole area here is no longer aerated, and the lung tissue has collapsed. In order for us to open up this lung, we need to get rid of that mucus plug. So this baby might be placed right side up, might get some aggressive suctioning. You can see by what they've done here, this side of the lung is very inflated. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Almost 10 ribs expanded. So they've really gone up on their ventilator settings to try and open up this lung. The problem with that is that this side is now way overinflated, You can see that this heart is pretty small because of this increased pressure, and this right side is still down. So now here we have what we call patchy infiltrates. You can look at this X-ray. This looks like a baby who has bad chronic lung disease. He's overinflated. Let's count his ribs. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. His diaphragms are pretty flat. They're not those nice bell curves we're used to, or they're nice curves that we're used to looking at. We can see that there's lung tissue seen around the heart. And you can see that there are these patches of white area. Some of them even overlie the heart. So this baby has overinflation with these patchy areas of atelectasis. Now we talk about air leak syndromes. So there's two types of air leaks. One is, it's in good position. So let's talk about some of the wacky stuff we see on X-ray. So an X-ray can help us look for cardiac disease. The baby comes in, we're having difficulty oxygenating the baby, we get an X-ray and has an abnormal looking heart. Just think about the other hearts that we have seen on our previous X-ray. This has kind of a long stem with this globular area. People will call this a boot-shaped heart. This is something that we would see with tetralogy of Fallot, boot-shaped heart. We have a baby come in from the delivery room that has a huge heart and they have an oxygen requirement, and we can't oxygenate the baby very well. This can only really be one thing, and that's Epstein anomaly, which is a problem with the tricuspid valve, making the right side of the heart huge. So what we're seeing here is a huge right side of the heart. So this is a baby that obviously has something dramatically wrong with it, this X-ray. What is all this stuff up here, these little circles? Notice that there is no abdominal gas down here, and that here we have placed a arterial line, but it's way over here on the right side of the body. This aorta and this heart, everything is being pushed over to here. This is the baby's intestines because there's a diaphragmatic hernia. The majority of diaphragmatic hernias are on the left side of the body. So we will see intestines, sometimes the liver, the stomach will often be up here in the left side of the chest. So now we're going to look at a couple of X-rays that show why positioning and making sure that there's nothing underneath your baby is so important. Now that you know how to read a chest X-ray, you'll see how different things will impact our ability to properly read that X-ray. So you can see, looking at this film, it's difficult to get a good idea of what's going on with this baby. For one thing, it's most obvious that there are here's the lead coming across the chest. This baby, it looks as though this temperature probe is coming off here, circling back around, and coming probably under the baby here. It's just a very busy film with a bunch of wires over it. You can see that the baby wasn't held because he's not flat. You can see his vertebral column kind of curves here. His heart, it's hard to say if we can see any heart borders or not because the baby is laying a little bit on his side. It might have been difficult for the nurse to hold this baby because we see that there's a chest tube in place. So she might have been afraid to move the baby much. However, that being said, we can see that it's more difficult to get a good idea of if there's a pneumothorax here with this chest tube in place because we can't really see the lung field, and also the baby is laying almost on his side. ribs are very long, and these ribs come around, and the baby's vertebral column, like we said before, is very curved. So we can't tell whether the baby's airway is straight or what's going on in this film. So this is a good representation of how position is very important. If we're looking at the lung fields here, we can't really say anything because this baby truly is laying on his side. He might have seemed like he was straight in this film, but you can see that we're looking at the sides of the vertebral column. These ribs appear to be very long, and these ribs appear to be coming around. You can see the back of the ribs. So this baby is laying on his side. His legs and his hips are going towards the right here, and his legs are going towards the left. Also, the X-ray tech has cut off the airway. If this baby is intubated, I don't know where the ET tube is. So if you have a film that cuts off the major structures that we're looking for, you have to tell the X-ray tech to take the X-ray again. It's not so important that I see this baby's femurs. Here they are here. What I want to see is this baby from his abdomen up into his airway. That's the important part that I am looking for. Also, this baby has a wire coming across, and he's probably laying on it. And the nurse probably thought that the leads were off the chest. The temperature probe is nicely off the baby, but she forgot to check underneath the baby. This X-ray had to be repeated. So this was so close. The nurse took a lot of effort in getting this film taken. You can see that she's put the leads off to the side. There's no temperature probe coming across our field. The baby's airway is midline. The baby is being held and is flat. Here we have the vertebral column is very straight. The ribs appear to be equal on either side. The cardiac silhouette here is very nice in the middle. However, what we're looking for in this particular patient was an aspiration. And as we said before, aspirations usually show up in the right side, right about here. This structure here is the baby laying on his high flow tubing. So everything was off the front of the baby, but the nurse hadn't swept underneath the baby to see if the baby was lying on anything. So this tubing was exactly across where we were looking. So look at your films after you take them, see if they're easy for you to read. One of the things that helps with X-ray interpretation is being able to correlate that X-ray with the clinical history and with what's going on with your baby at the time of the X-ray. If you don't understand why we're getting an X-ray, ask. And also, once the X-ray is done, ask to go over it. And if we have time, we'll stop by and we'll go over the X-ray and show you exactly what we see. For example, looking at this baby, you can see this is an old preemie. He's got very chronic lungs. He's well inflated. He's obviously on high flow, but he's got these chronic kind of patchy areas showing some lung damage, scarring, inflammation. This is typical for an old preemie. So if you have any questions or if you like this format, we can do another session looking at abdominal films. Let Sonia know and I'll get right on it.